So shown here on the left is a laparoscopic view of the peritoneal cavity of a 7-year-old girl from California whom we saw a few years ago, who has TRAPS, the TNF receptor-associated periodic syndrome. And this is one of the periodic fever syndromes that we'll be talking about today. She had had repeated episodes of peritonitis over the course of her young life and actually had developed adhesions in the peritoneal cavity, which are shown here, because of this repeated inflammation, this repeated sterile peritonitis that she had. Second image here is actually an echocardiogram taken of one of our patients with familial Mediterranean fever, a young man from Baghdad, Iraq, who was sent to us via London and then the Mayo Clinic with diffuse amyloid deposition due to FMF, and we'll talk a little bit about that. It's rare to see amyloid deposit in the heart in FMF, but in this particular case it did, and in fact this young man was in heart failure at the time we saw him, with an ejection fraction of around 37% at the age of, I think he was 18 at that time. And here's an image of a patient with NOMID, the neonatal onset multisystem inflammatory disease, another of the recurrent fever syndromes that we'll be talking about. And this is basically a magnetic resonance image taken of the brain of one such patient. And you can see all the whitish areas here represent inflammation. This is chronic aseptic meningitis in this child. It leads to mental retardation, blindness, and deafness in these patients. So it's really a very serious and debilitating problem for patients who have this disease. In any case, as Francis mentioned, really we saw this as an opportunity, having diseases that are caused by single gene disorders, to identify what those genes are, learn about new genes and pathways that regulate inflammation in humans. Because after all, if these kinds of clinical conditions result from those genetic mutations, they must have some important role in human biology. And so we thought that that was a critical insight. And these diseases also serve as prototypes for a group of diseases that we now call the systemic autoinflammatory diseases. These are a group of diseases that span a greater spectrum than just the hereditary fever syndrome, but they have in common the fact that there is unexplained inflammation, either recurrent or chronic inflammation, in the absence of high-titer autoantibodies or antigen-specific T cells. And it turns out that a lot of these disorders are, in fact, disorders of the innate immune system as opposed to the adaptive immune system, which has abnormalities in more traditionally recognized autoimmune diseases, such as systemic lupus or rheumatoid arthritis. So, in any case, the first patient that actually got me interested in these diseases was a man that I saw a number of years ago. It was actually 24 years ago at this point when I was a beginning fellow here at the NIH back in 1985. And he was, at that time, in his early 20s. His name is Sarkis, and he's of Armenian ancestry. And he presented to us, basically, with a history of episodic attacks of mono or quasi-articular arthritis in the knee or the ankle, dating back to infancy. And he had had these attacks roughly once a month for his whole life. So he had had, at the time that I saw him, hundreds of attacks. During these attacks, he would have fever and an erythematous rash over the involved joint with massive joint incisions, and when he would have his joint aspirated, as sometimes happened if he happened to see a rheumatologist, there would be loads of polymorphic leukocytes in the synovial fluid on the order of 100,000 per cubic millimeter, which is what you would see in a septic arthritis. The attacks would last on the order of several days. It would occur about once a month, and he had minimal response to corticosteroids. Now, at the time that I saw this man, I actually didn't know what he had. He was referred to us at the NIH patient clinic as an unknown, and he was also an unknown to me. But fortunately, my attending was Paul Plotz, who suggested the diagnosis of FMF just based on the Armenian ancestry. And in fact, there was a fellow from Israel who happened to be in the lab that I was working in who said it was obvious that it had to be FMF because I see it all the time in Israel. Classic textbook case presentation. So this had sort of gotten me interested in FMF, and of course I learned as I started following Sarcus that in fact this is caused by a single autosomal recessive gene, and at least back at that time in the mid-1980s there was a tremendous amount of excitement, at least in part of it incited by Francis with the work that he was doing on cystic fibrosis, that in fact we had the opportunity, using the new tools of human genetics and positional cloning, to identify some of the genes that underlie these conditions. And in that way, we could, without entertaining a lot of perhaps wild goose chase hypotheses, we could actually cut through the Gordian knot and be able to get to the heart of the matter and figure out what's going on in these patients. So that really appealed to me. And just for those of you who aren't familiar with FMS, there could be any such people in this audience, just a few images that perhaps will illustrate features of FMS. So just by a little way of background, the attacks of FMF usually last on the order of 1 to 3 days. That's actually quite important in the course of this talk, because we'll be talking about patients that have other periodic fever syndromes where the duration of the attacks is much different. So remember that 1 to 3 day attack is usually seen in individuals of Jewish, Arab, Armenian, Turkish, Italian ancestry, and some of the clinical features are shown here. One of the things that these patients frequently have, which our patients that I just told you about did not have, is episodes of peritoneal inflammation, and these are just pure fluid levels on an upright film of the abdomen. These patients can also have pleural inflammation, they can have pleural effusion. Rarely they can have pericarditis. You can see in this case posterior pericardial effusion. Arthritis, as I mentioned, is a common manifestation. It's usually a non-deforming arthritis, although prior to the advent of colchicine treatment in FMF, chronic arthritis of the hip was seen, at least in some patients. And then there's a rash that's called erysipeloid erythema, a reddish, raised, fairly well demarcated rash that usually occurs on the dorsal of the foot, the ankle, or the lower leg. Histologically, what you see is lots of polyps, as I mentioned in the case of our positive patient. And these patients sometimes can develop systemic amyloidosis. This is basically due to the deposition of a cleavage product, serum amyloid A, which is one of the acute phase proteins that's made during the inflammatory response. And it deposits in a number of vital organs, including the kidneys, the gastrointestinal tract, the lungs, the liver, the thyroid, rarely the heart. So in any case, I did get interested in positional cloning, maybe not immediately after seeing Sarcus, but within a couple of years.